Good evening. My name is Mark Bialik. I'm the Executive Director of the Rhode Island Academy of Physician Assistants. Thanks for joining us. We're here to talk tonight about PA practice in Rhode Island, where we are today, and how we're to improve for tomorrow. I want to thank Ann Davis and Carson Walker from RIAPA, the American Academy of Physician Assistants, for joining us today to put on this webinar. I'm going to let them introduce themselves and go on with the webinar, which is being recorded.
Thank you, Mark. Thank you. Good evening, and thank you very much for not only inviting us to speak, but also for taking time out of your busy schedules this evening. We're absolutely delighted to present on the topic of PA practice in Rhode Island, where we are today, and how to improve for tomorrow. You can see on this slide who we are, but just a bit more background. I work with our state chapters in the Northeast region on improving state laws and regulations, including working closely with Jim Carney and the other leaders of the Rhode Island Academy of PAs. Ann Davis directs all of the work we do with our constituent organizations. In April, Ann and I had the good fortune to meet at the Rhode Island Medical Society headquarters with your Executive Director, Newell Ward, as well as the Director of Membership, Mark Bialik. Earlier that same day, Ann and I presented to the Massachusetts and Rhode Island section of the MGMA. The Rhode Island Medical Society Director of Government and Public Affairs, Steve DeToy, was in attendance. I can honestly say that of all the chapters I have the pleasure of working with, none has a stronger relationship with the state's medical society than the Rhode Island Academy of PAs. As we will get into, I think this strong partnership has resulted in many of the laws and regulations in place in Rhode Island. So first, an overview of our presentation. We'll take a look at a snapshot of the PA profession with a focus on Rhode Island and how the practice environment for PAs in the Ocean State compares to the practice environment of other states. Then we'll discuss outdated laws and regulations that are impeding maximum utilization of PAs. We'll then discuss the new policies that have been developed in response to the rapidly changing healthcare system. And we will leave plenty of room at the end for any questions you might have about the topics we cover or anything else related to PA practice. I want to start by talking about PAs in Rhode Island. The state has been a good place for PAs to practice, and that is reflected by Rhode Island ranking 35th out of 51 jurisdictions in PAs per 100,000 people. As you can see from this slide, emergency medicine is the top practice area of PAs in Rhode Island at nearly 20%. Nationally, emergency medicine ranks as the third most popular practice area at 13%. The top practice area of PAs nationally is family medicine at 21%. It should be noted that 18.8% of Rhode Island PAs work in primary care. That's compared to a national average of 28%. This next slide shows the top practice settings for PAs in Rhode Island, where the hospital setting accounts for more than 51% of PA practice, while office-based settings account for just under 35%. This is actually a reverse of what it is nationally, where just under 44% of PAs practice in an office-based setting, while 38% practice in hospitals. Now, many of you may be familiar, many of you may work with PAs and are familiar with PA education, but here's a quick overview. PAs are educated in the medical model at master's level accredited programs, similar to Stanford's curriculum, which is outlined here. We were going to use either Bryant or Johnson & Wales as an example, but neither had as nice a graphic as Stanford. But I will say that all three are similar in terms of curriculum and timing. The typical PA program extends over 27 continuous months. That's the equivalent of 3 academic years and is broken into 2 phases: didactic, the graduate courses, and the clinical phase. The didactic phase includes courses in anatomy, physiology, pharmacology, physical diagnosis, behavioral sciences, and medical ethics, while the clinical phase consists of rotations in medical and surgical specialties, including family medicine, internal medicine, general surgery, pediatrics, obstetrics and gynecology, emergency medicine, and psychiatry. Graduating PA students have completed approximately 2,000 hours of supervised clinical practice. Now, as the PA profession turns 50 this year, we are committed to assuring that it keeps pace with changes in the healthcare system. Decades ago, when states began to pass laws authorizing PA practice, there were many unknowns about this new profession. Because the profession was new, many state laws and regulations included provisions that seemed indicated at the time. PA advocates likely agreed to these provisions because PAs were something of an experiment. Well, 50 years later, the PA profession has grown from 3 PAs and 1 PA program in 1967 to 224 accredited PA programs and more than 115,000 PAs. Today, we know a lot more about PAs, the rigorous education they receive, and the high-quality care they provide. Now, about 10 years ago, AAPA identified 6 key elements of a modern PA Practice Act as a partial way to measure how well each state allows full utilization of PAs. These elements include using licensure as the regulatory term for the profession, authorizing full prescriptive authority for PAs, allowing scope, collaboration details, and chart review policies to be determined at the practice level, and allowing physicians to work with the number of PAs that is appropriate for the practice setting. You can see how many states have achieved each element. The next slide shows the number of key elements each state has achieved. Now, last year we achieved the milestone of one of our key elements being adopted in all 50 states, when Ohio adopted use of the term licensure. 7 states, shown here in navy, have adopted all 6 key elements, and more than 30 have adopted at least 4. Rhode Island was the first to adopt all 6, and actually did so in 2004, a few years before AAPA formalized the 6 key element concept. This achievement by the Rhode Island Academy of PAs was due largely to the progressive thinking and support of the Rhode Island Medical Society. The 6 key elements are necessary, and we continue to support their enactment in all states. The goal is to have this entire map navy blue. But the 6 key elements alone are not sufficient to fully realize the potential of PA practice. Why? 2 reasons. First, with 50 years under the profession's belt, research shows that PAs provide high-quality care. The provisions included in early PA state laws to assure quality, like specific physician oversight and responsibility requirements, have been proven to be unnecessary. There are more and more studies published that provide evidence about the high-quality care that PAs provide. For example, a 2016 study conducted by the Peterson Center on Healthcare and Stanford University's Clinical Excellence Research Center ranked the best primary care practices in the country. The study found that the practices ranked the highest ensured that PAs are able to work to the full extent of their education and experience. Now, the second reason the 6 key elements are no longer sufficient is the healthcare marketplace has changed dramatically. The profession and the rules that govern it must also change. Let's talk about the marketplace for a moment. The incentives for physicians to supervise and take responsibility for care provided by PAs are diminished. Years ago, most physicians owned their own practice. They could benefit financially by supervising PAs and taking on the extra liability. Today, physicians are more likely to be employees. And as employees, there's no personal financial advantage to supervising a PA and taking on the liability of supervising a PA. That puts PAs at a disadvantage relative to NPs in states like Rhode Island, where NPs have independent practice. So to address marketplace changes, there are some areas that can be improved in state law. The first is replacing the term supervision with collaboration, which is a more accurate description of the way PAs and physicians work together. The second is to base PA scope of practice on PA education and training, rather than solely on physician delegation. The third major change is to shift responsibility for the PA's actions from the physician to the PA. When initial laws were passed, this type of language was put in as a quality control measure. This removal of responsibility language was actually brought to our attention by leaders and lawyers within the Medical Society of Virginia when we were looking at revising the PA Practice Act there. The final major change is to remove any and all references to the PA as an agent of the physician. In the past, this seemed sufficient to assure that PAs were included in provisions of law or regulation that mentioned physicians. However, over time, what we discovered is that more often, if PAs weren't listed individually as being able to do something, then they were excluded, and this approach was no longer sufficient. PAs need to be listed individually among providers. Now that we have discussed these revisions, let's review how it might look in practicality in Rhode Island. On the left is current Rhode Island statute, and on the right is language that was included in last year's legislation that would have incorporated these changes, H7489 and S2639. This was legislation supported by the Rhode Island Academy, and it's important to note that the Medical Society supported this legislation as well. As you can see, it would make the change from supervision to collaboration. And I'll allow a moment here for you to review these changes. Next up is the change in scope. As you can see, the left discusses parameters on scope related to the physician's scope of practice, while the right refers to the PA's scope being defined by what's within the PA's education, training, and experience. It should also be noted here that facilities would still conduct credentialing and privileging, so there's no reason to worry about this change in scope. I'll leave a moment here to review again. Next up is the shift from physicians being responsible for PA care to PAs being responsible for the care they deliver. As you can see, physician responsibility language is currently part of the definition of a PA. Again, I'll allow a quick moment here. And finally, we have the removal of agency language. And with that, these are the proposals we are talking about in Rhode Island with the Rhode Island Academy. I'm going to turn it over to Anne to talk about how these proposals fit in the bigger picture, as well as some additional issues we are working on in states.
Thanks very much, Carson. If you'll go ahead and move to the next slide, please. Great. I want to make sure that you can hear me okay. Am I audible?
Perfect.
Thank you. All righty. So thanks, Carson, for the opportunity to talk here. I'd like to take just a moment, time out, and say that some may say these changes mean that PAs are wanting to absolve themselves from team practice, and really that's far from the case. We recently surveyed our membership to find out what PAs thought about team practice, and over 96% said they believed that the physician PA team was a time-honored and well-tested method of providing health care and had no desire to disrupt that. So the changes that we're talking about don't mean at all that PAs want to practice independently. We are fiercely committed to team practice with physicians. We have a great appreciation for the depth of PA education, and we count on it every day in practice. And of course, as an academy, AAPA is interested in continuing to partnership with physicians and physician organizations to work to improve the ability of teams to provide care without unnecessary or antiquated regulatory burdens. Next slide, Carson. Great. We think there's some benefits for physicians with the proposals that Carson presented just a moment ago. The first is that everybody's concerned about physician burnout. We know it's a real problem. And we also know that administrative burden adds to physician burnout when people are having to spend extra time with paperwork or forms or extra administrivia. It diminishes and decreases time with patients, and physicians don't like that. Physicians want to be able to take care of patients without extra administrative burdens. Also, eliminating physician liability for care provided by a PA, we think that's good for physicians too. There's no reason for a physician to be held liable for care provided by PA if they weren't involved. It allows for flexibility and creativity for team practice and design to be determined at the practice level, and we think that it makes good sense for physicians to have the ability to configure teams in a way that is useful for their method of caring for patients. We want PA regulation to be informed, so PAs should participate in regulation of the profession just as they do in Rhode Island. And we think that collaboration is a better term for how physicians and PAs work together. Next slide. The fact that we have some policies or ideas or metrics on the national level doesn't mean that we are in any stretch dictating to states or state chapters or our PA state organizations what they should do. The role of a national organization is both to research and adopt policy, but then to make it clear that it's up to the individual state to determine which kind of policies will work best for them. Every state has a unique set of circumstances, unique patient problems, unique configurations of their workforce and healthcare systems, and we firmly believe that our state chapters make the best decisions about how they should pursue changes. We do think another job of a national organization is to work on the national level to change federal laws and regulations to help us implement our new policies. Next slide. So a couple other things that we're working on the national level and to bring some suggestions to our state chapters. The first is streamlining licensure procedures to increase license portability. Certainly those of you in Rhode Island know a lot about this because many of you are licensed in more than one state. Something we call harmonization acts, more about that in a moment, and then adding PAs to workforce legislation. Next slide. So what about streamlining licensure? These are the things we seek in licensing. Licensing is a very critical part of regulation of health professions, and while it should be should put people under appropriate scrutiny, there's some administrative aspects of licensing in some states that really make it burdensome and make it take too long. So it should be done, we believe, as an administrative act. It shouldn't require a board to make a decision, unless, of course, there's an applicant who deserves the board's scrutiny. Secondly, we don't think it should require personal interviews for routine applications. A PA's license should not be tied to a physician's license, and letters of recommendation always slow things down. I don't know if you have several on your desk that you've been requested to write, but it takes a while for busy people to get to those and can slow down the process. We don't think the state should have to approve or receive a practice agreement, and we don't think a jurisprudence exam should be required. We believe that health professionals have a responsibility to know about the state law, and it should be left at that. Next slide. Well, let me just say that Rhode Island does quite well in terms of streamlined licensure. The one thing that could be improved is that the PA board does actually vote on routine applications. We think that's probably an unnecessary step. Second thing here is this also helps with increasing license portability, which makes it faster for licensees to be licensed in multiple jurisdictions, and certainly can help with things like telemedicine. And some PAs are working in systems now that utilize telemedicine. Certainly some follow-up with patients via telepsychiatry is now happening with physicians and PAs working together. A recent new development is that a uniform application for PA licensure was just launched. It was developed as a joint project of the Federation of State Medical Boards and AAPA, and Oklahoma has piloted the uniform application for PAs. We know that Rhode Island adopts the uniform application for physician licensure, and we're hoping that Rhode Island can be among the next states to adopt a uniform license for PA licensure, uniform application for PA licensure also. Another thing we're looking for is to launch a compact for PAs. You've probably heard about the Interstate Compact for Medical Licensure, and we know there was a bill in the Rhode Island legislature last year to have Rhode Island adopt the compact. It didn't pass last year, but my hunch is that RIMS will be supporting that again in the future. Thanks, Carson. Next slide. We're also looking at what we call harmonization acts. There's a bunch of health law that is outside the PA law that says that licensed health professionals must do certain things. For example, to report certain kinds of wounds or to report elder abuse or child abuse. Lots of times these laws will say physicians must, or physicians and nurses must, and really they are intended to apply to PAs too, but in some of them, the laws either were written before PAs were widely deployed in that specialty, or the laws were assumed it's because it said physician that people would think it meant PA too, but really it's better for everybody if the laws specifically mention PAs, if they intend to include PAs. So we're working with our state chapters on things we call Harmonization Act that just adds PAs to multiple code sections to reflect what PAs are already doing. It doesn't increase PA scope of practice. It just makes it clear that PAs should be included in those sections of health law. Next slide. We're also working to include PAs in healthcare workforce bills. There are some states that will pass laws that will incentivize healthcare providers to, for example, work with certain populations or in certain areas or in certain specialties. And we believe that these are applied to physicians, for example, or physicians and advanced practice nurses, that PAs should be included too. There's a big shortage of health professionals who will serve as clinical preceptors. So now we're beginning to see some bills that incentivize preceptors for clinical teaching. The initial one was in Georgia, led by the Georgia AHEC, and this has spread to several other states, and it actually lets you declare less income for the purpose of state income tax if you precept students up to a certain number and in specified specialties. Next slide. I'm going to talk for just a moment about some of the research on PA quality and outcomes and cost effectiveness. For many years, PAs just weren't well studied. There's actually sort of a bimodal distribution of PA research on the PA profession. A lot of studies in the 70s and early 80s when PAs first arrived on the scene, and then just not much and nothing for about 20 years. And then in the early 2000s and continuing until now, the current time, we're finding that there are an abundance of health service researchers, physicians, PAs, and others who are studying PAs and care provided by PAs and comparing it to care provided by physicians, which of course is completely fair. If PAs are going to be practicing, then they should be held to a high standard, and that should be something that's evidence-based and documented. This study by Kurtzman and Barnow looked at patterns of practice and quality of care and showed that PAs and NPs delivered similar quality of care and services and referrals, and this was done in community health centers. Next slide, if you would. This slide by Duriani and Ramsey studied diabetes and cardiovascular disease care and quality, and found that the care provided by PAs and NPs was comparable to that provided by physicians in these two specialty areas. Next slide. Cost effectiveness has also been a topic of research, and here Timmons, published in Health Policy, looked at what it did for the healthcare cost of Medicaid patients if PAs were authorized to prescribe controlled medications, and it actually found a decrease in cost. And you can imagine how this works, that if you don't have to go interrupt a physician to write a prescription or have a patient come back or go to another clinic to pick up the prescription, it can reduce the cost per episode of care. We've put together a bibliography of articles on the PA profession, and you can see on the very bottom there's a link to the articles and reports. Next slide, if you would. There's been some interesting and innovative things happening in other states, and I want to just touch on two of them. In Michigan, the Michigan Association of PAs and the Michigan Medical Society worked for a couple of years to put together a bill, which was the Michigan House Bill 5533, supported by the physicians and the PAs. And both groups wanted to get away from the term supervising physician. They wanted to make it clear that while PAs and physicians practice together, the physician didn't need to assume responsibility or liability for care provided by the PA if the physician wasn't involved. And they also wanted to allow for more creative team design. So they Now PAs and physicians work together. PAs practice with participating physicians. There's no delegation. In order for the PA to get to work, rather the scope of practice is defined by the PA's education and experience. And they repealed their ratio restrictions, something that Rhode Island did years ago. So this has been a very interesting bill to watch, and we're hoping that this is a trend that will spread to some other states. Next slide, please. Just this summer, West Virginia passed Senate Bill 347, which again moves from supervision, a term that both the physicians and PAs were ready to get rid of. Now PAs practice in collaboration with physicians. There was a provision in the West Virginia Code that required PAs to maintain current certification by the National Commission on Certification of PAs for license renewal, and that was repealed. There has long been a PA member of the medical board, and this added a second PA to the medical board. In Rhode Island, PAs are regulated by the PA board, and there's a physician member there. But because PAs in West Virginia are regulated by the medical board, they sought to have increased representation, and indeed the bill was supported by both the PA and physician organizations in the state and was passed and signed by the governor. Next slide. I was going to mention a quick note that Illinois, this is just late breaking news, just a couple weeks ago, passed a similar bill changing to collaboration from supervision, and that bill was also drafted in conjunction with the Illinois Medical Society. So kind of to wrap up here, those of you who work with PAs know that in general, PAs are team players. They're folks that like to work together with others to take care of patients. A couple of years ago, there was a study that showed that 93% of Americans say that PAs are trusted healthcare professions. So the brand is good and improving. PAs like to take care of patients and are eager to connect with all kinds of folks in order to make sure that that gets done. I have a friend who works in nephrology, and she says, you know, I'm the person that can call the patient's grandmother and the patient's vascular surgeon, and they both call me back. So that spot in the healthcare hierarchy of helping to connect people together is part of the PA DNA, and I think one of the things that makes PAs so valuable. And of course, part of that is our strong connection with physicians. Next slide. So that's what we came to talk about today. I know we're doing this as a webinar, so you should feel free to contact either Carson or I if you have questions. So Carson, if you put up the next slide there, this shows our contact information. And with that, I'll turn this back to Mark.
Ann and Carson, thank you so much. I want to thank the Academy of Physician Assistants for letting us have you so much of your time. We really appreciate it. I'm glad you're able to do this webinar. I recorded it so we can share it with some of our local Rhode Island specialty societies and the medical society members, the board and the council. Again, just thank you so much for taking time out of your schedules. We appreciate it, and we appreciate your support of the Rhode Island Academy of Physician Assistants.
Thanks a bunch, Mark.
Thank you very much.
Thank you so much. I'm going to end the webinar now. Thanks.